Welcome back to Takacs and McGinnis Elder Care Law Hour, where we explore the many issues that arise due to aging, disability, and unexpected illness. I'm your co-host, Tim Takacs, and today we're talking about the opioid crisis and other addictions and how they affect seniors.
And I'm Barbara McGinnis. As we continue this episode, in this segment we're going to be talking about legitimate pain management. How do you manage chronic pain, and how has the battle against the opioid crisis affected treatment? We're going to be talking with Dr. Greg Thompson, who is the president of LifeLinc Corporation and LifeLinc Pain Management Centers. Welcome. Good morning.
Thank you very much. Appreciate you having me.
So tell us about what is pain management.
So pain management is really a branch of the field of medicine in which practitioners treat patients with pain problems, and they can be acute or chronic. That pain could be the result of a disease process or an injury. The pain itself can be the primary problem. So we treat both of those, and so a pain practitioner would be a physician that usually comes from the field of anesthesiology, but not always. But they've done extra training or special training or a fellowship to just further their education in that, and then we treat those patients and just concentrate really on trying to get those patients back to a good level of function and managing their pain.
So when would someone need to see a pain management physician, and what can they expect at a typical visit? Okay,
so there are a couple instances. A patient may see someone like us in an acute setting, and particularly a hospital, in correlation with a surgery, where we manage their pain during that surgery. But what we're talking about here today is more in an outpatient clinical setting, in an office, in a pain setting. So that's usually a chronic pain condition, and so by definition we look at chronic pain as being pain that's 3 months of duration or longer. And so generally those patients have been treated by another practitioner, their family practitioner, or some other physician who has just got to the point where they can't manage that pain any longer, or the modalities they've tried are no longer effective. And so they'll refer that patient to a pain specialist or someone like us, and then we see that patient. And so for instance, like the Center for Disease Control, we see a lot of back pain. Well, they show that 85% of adults will have a significant incidence of back pain in their adult life. And so that's a big socioeconomic impactor, back pain, and it's actually the #1 cause of loss of work days. And so we see a lot of that, and so those are the type of patients that we see.
You mentioned referral. So would a potential client or patient need a referral from their PCP, or would they just be able to call one of the pain management centers and say, I need to be seen?
So generally, most pain centers are referral only, and a lot of that has to do with some of the new regulations in the states, and that is just to kind of prevent people walking in off the street saying, hey, I need a prescription. So it's usually referral only, and most of the centers operate that way.
Of course, this episode is about addictions, and specifically the opioid crisis. What do you do, or what does your pain centers do to maybe mitigate those possibilities?
And that's a huge concern, obviously, for us, and it's the big focus with everyone these days, the medical practitioners, the state. So when a patient comes in, it's going to be much like any other doctor visit. We're going to do a lot of evaluation and taking histories and physical exams and what modalities have worked, what haven't worked, and then we kind of design a plan, because our goal really is not so much how do we get rid of all your pain, but how do we manage your pain? How do we get you back to life? How do we get you to a level of function? What is it that you like to do each day? Do you play golf? Do you garden? Do you go out and do different activities? So how do we do that? With particular focus on minimizing the narcotics, which are the opioids, and so we look at different modalities. So a lot of our treatments may be around physical therapy, interventional injections, massage therapy, behavioral modification, behavioral therapy, and then there are sometimes patients that do need narcotics and chronic narcotics, and then there's a whole monitoring system for that. But it's not primarily narcotic based as much anymore.
Right.
So as I was reading, what about risk factors for addiction? Some people are more prone to becoming addicted than others. Is that right?
Absolutely.
Okay.
And so when we talk about addiction, that's a scary word, and people think, I take a pain medicine, I'm going to be addicted, and that's not really true. There is that risk. So there's two things we talk about. There's physical dependence, and then there's addiction. So physical dependence is your body getting used to a medication, particularly in the narcotics. You take it for a while, your body gets used to it. The same dose doesn't work, so we have to increase the dose over a long period of time, and that's kind of the physical dependence. Addiction is a whole separate issue. It's a chronic disease in and of itself, and really that is treated by an addiction specialist. There's a lot of behavioral issues with that, and so addiction is more centered around people craving or obsessing about the medication. Certainly someone is at risk for that. So we look at a risk for that of addiction would be alcoholism, previous drug use, previous drug addiction, certain mental illnesses. Those would be risk factors for someone being addicted. So the average patient isn't quite as much at risk for addiction as they are just for physical dependence, which is a whole different thing and a manageable thing.
If you, in treatment, in pain management centers, if you see the addictive personalities as well, do you have the mental health specialists on staff, or is that a separate referral?
It's usually a separate referral, and we have those referrals to that's what I said earlier about behavioral health and or addiction specialists, and so that we can refer those out. Yes.
So how do you address pain in seniors? Is that different, or is it or they have different physiology that makes you approach those patients differently?
Well, it's the same and different. I mean, every patient is different, but we approach it the same. I think the thing that we worry about in the elderly population is just some of the side effects of the narcotic medications and some of the issues that seniors have. As we age, our balance is an issue. So we don't want to give medications that may cause dizziness or issues with balance and make that worse. We don't want someone to fall. Confusion is, so that can be an issue with narcotics. So we'll tailor those medications specifically, and there's a lot of what we call our multimodal pain methods, so non-narcotic pain methods that
you referred to earlier, similar
to those. So all
these
these other medications that are not narcotics, but that allow us to reduce the dose of narcotics by using those as well.
Right.
We've talked about new regulations, new laws, I guess, for prescribing. Are the practitioners at the pain center exempt from those new laws?
The practitioners are not. So a lot of the new regulations, there's really two sides. Ones that the patients would see, and then ones involving how the practitioner practices. And so these are the things that the physicians have really had to bone up on and figure out how to do this correctly. And so there is a prescription data bank that monitors prescriptions. So if you write a narcotic for a patient, you have to access that data bank and check any other prescriptions that patient has had in the last 30 days. So that kind of prevents the doctor shopping patient that gets a prescription that goes next door and gets another prescription and goes next door and gets another prescription, so that how many prescriptions they've had.
Because in the past we counted on pharmacies to be sort of like the little gatekeeper, but
that's right.
If you go to multiple pharmacies, but now there's a data bank.
So the pharmacy is in on that, and the physicians are in on that, and they're all part of that data bank, and so we all access it. So we're all part of the same team looking at that. We also have to make sure before we write any kind of prescriptions that we have a full exam, a full history, a full diagnostic code, and all that has to be put in. Where the patient sees it on the other side is they don't get the large prescriptions that they got in the past, which is probably a good thing. People would have surgery and then they have a half a bottle of pills left over that they never used.
Right, like we were just heard is an accidental drug dealer.
Absolutely. And that is where we get the diversion and people just having it in their medicine cabinet. People pick it up and they take it, and so the new rules are you get a 3-day prescription for an incident.
Gotcha. So Dr. Thompson, thanks for being here. We're going to put your contact information up, LifeLinc Pain Centers, 615-380-8484. Glad to have you here.
Great, thank you.
Next up, we will be discussing a new phenomenon resulting from the opioid crisis, which is grandparents raising grandchildren. Stay with us.